Okay, good afternoon, everyone, and welcome to this inaugural seminar series at the Center for Global Health. And thanks for showing up on a stormy day like this, so we're starting with a bang. May I introduce Dr. Ted Trimble to say a few words. As you all know, Dr. Trimble is the director of our center. Okay.
Thank you for coming. I'd also like to thank Sudha Sivaram and Damali Martin, who is not here, and Makeda Williams, who have been putting together our speaker series. This was based on the hard work that DCCPS did in putting together their speaker series for global health, and our DCCPS colleagues very generously agreed to let us have a unified trans-NCI global health speaker series. So we're very grateful to our friends at DCCPS for laying the groundwork for this and for joining in the overall effort. We're happy that you could be here. We invite your suggestions on speakers. We have some money set aside to help pay for speakers, but we're always happy to have people who are distinguished and local, as well as if people are coming in for other meetings and we can arrange for them to spend an hour or two with us, that's great too. So, Sudha, will you introduce our speaker for today?
So it's my pleasure to welcome and introduce the distinguished and local Dr. Jeremy Shiffman, who is Associate Professor at American University. I've got his bio here, and I'm going to read quickly my view of his highlights. He is a political scientist by training, and he conducts research in the politics of health policy and administration in low- and middle-income countries. He has a particular interest in health agenda setting, particularly why some issues receive priorities while others do not. He has investigated several topics in global public health, including maternal child health, newborn survival, family planning, donor funding for health and health systems reform. So I look forward to learning from his wide experience there. His research has been funded by the Gates, MacArthur, and Rockefeller Foundation. He's widely published. He received his BA from Yale, an MA from Johns Hopkins, and his doctorate from the University of Michigan. So Jeremy, it's an honor to have you here. Welcome.
Thank you very much. It's a real privilege to have an opportunity to speak with you, and I really appreciate the invitation. It's also a very pleasant surprise for me. I discovered 3 former students of mine in the audience from Syracuse University, 2 of whom I didn't know would be here, one of whom actually worked on the grant proposal for the project I'm going to describe. So thank you, David.
I'm delighted to be here.
So thank you very much for this invitation. I would like to present to you, I may need some help in this. Oh, it's right here?
Right here.
Okay. I'd like to present to you some preliminary results from a 3-year research project that I'm leading on the effectiveness of global health policy networks, and I will mention shortly what I mean by that. And I want to acknowledge the funding that we received from the Bill and Melinda Gates Foundation for this work, as well as the 12 researchers who are on this project. So what I am going to discuss are 3 things: the motivation for this study on global health policy networks, our conceptual framework and our methodological approach, and some initial observations and the future research that we are planning. The basic motivation is this, that if you think across global health issues and the level of mortality and morbidity change across time, there's obvious considerable variance, differences. There have been, on some issues, some diseases, a considerable progress in reducing morbidity, mortality from diseases such as polio, malaria, tuberculosis. For other conditions, it's not so clear. For pneumonia, for maternal mortality, and as I'm sure is very apparent to this audience, for certain cancers. So how do we explain this? Well, the conventional focus in global health research it gravitates toward a consideration of epidemiology and especially interventions. Are bed nets available for malaria? Are vaccines, have they been developed for various vaccine-preventable diseases? But what we're asking as social scientists is, where are the actors? And this is an issue that has been surprisingly little researched by very few individuals. I've got the names of a couple who have paid attention to this. But this is a neglected area. Because the actors, the individuals and organizations involved, including organizations and institutions such as this one, help develop interventions. They mobilize attention and resources. They facilitate and encourage countries to adopt appropriate policy. And they facilitate and find ways to get interventions scaled up. And this is the crucial point, presumably some networks of actors do this better than others. Another piece of backdrop to what we're doing here is the observation that, especially over the past 2 decades, networks of focusing on global policy for dozens, arguably hundreds of issues have formed rapidly. And by global health policy network, we mean communities of individuals and organizations who have a shared concern for a particular issue. Most prominently in global health, we think of AIDS. But there are many, many other instances, and I'll give some examples. These could be individuals in UN agencies and government agencies, in the governments of low-income countries, and NGOs, researchers, and others. But what binds them is they all care about a particular health issue. Sometimes these networks are formalized. For instance, the Roll Back Malaria, the Stop TB Partnership, and of course, the recently formed NCD Alliance. But they're not all formal. For instance, behind the scenes, there are networks of individuals who mobilize globally to address the survival of newborn babies. There are folks who are concerned with the prevention of injury globally. Others concerned with neglected tropical diseases who both have formal and informal institutions. So what this project is that I'm going to describe and offer you some preliminary findings, the Global Health Advocacy and Policy Project, or GHAPP for short, is a 3-year initiative that examines the effectiveness of 6 global health policy networks in 3 paired comparisons, and these are the 6. I will explain the logic of the paired comparisons shortly. Can you all read the 6? Is that for those in the back, TB and pneumonia, tobacco and alcohol, newborn survival, and maternal survival. We're in our 2nd year, and I will be presenting the preliminary observations. The first thing I wish to do, though, is to present to you how we are conceptualizing the whole causal process. And this itself is a product of the research and is subject to ongoing evolution. And I want you to note that the arrows go both ways. It's not a linear conceptual framework. Let me speak to these 4 components: networks, environment, issue characteristics, and outcomes. First, the network itself. The set of organizations and individuals are linked by the shared concern for the issue. And here we are particularly concerned, especially with 2 dimensions. One is its structure. How is it organized? What does it look like? And here we're asking questions about, is it a formal organization or more informal? Is there a core group of individuals who essentially make all decisions globally about the issue, or is this a more diffuse network where power is dispersed throughout? The second element of network that we are focused on is strategy. What is it they are trying, how do they try to achieve what they're trying to achieve? How do they build allies? Who do they target? How do they go about making claims that the condition they're trying to address is severe and warranting of resources? How do they demonstrate that this is a surmountable condition or if not, that resources are needed to find how to surmount it. How do they neutralize opposition if opposition exists? So network is the first piece of this. The second is environment. And by this we mean all of the factors external to the actors that nevertheless both shape network formation as well as the policy and public health outcomes we're looking at. And the idea is that networks negotiate through these political environments. And some do so better than others. Some are more aware of what's out there, and others pay no attention. What do I mean by environmental factors? Well, one big one is other health priorities. Because any given issue, any cancer, any disease, any type of injury is always competing for resources amidst an environment of scarce resources. And sometimes that can pull away resources from that particular issue. Other times, if there's synergy between the issues, it may be supportive. What else do I mean by environment? Opposition. I'll talk a little bit more about something that everybody here is well aware of. So, for instance, to fight tobacco, well, there's a huge opposition to those who would seek to control tobacco in the form of an industry. AIDS has encountered conservative religious opposition. Other issues, like the survival of newborn babies, encounters minimal opposition. So there's variance in the level of opposition. And finally, global agreements. By this, for instance, we mean things like the Millennium Development Goals, things that global actors agree to and that put pressure on nation-states to act. And these exist for some conditions, but not others. So networks negotiate through environment. But the third element here is issue characteristics. And here, the idea is that issues, conditions differ in their difficulty to address. Some issues are inherently more difficult to try to tackle than others. They're more complex. For instance, some are more severe than others. They cause more deaths, and presumably if they cause more deaths, it's easier to gain attention and resources. Some are more tractable than others. There's a vaccine. So policymakers gravitate toward wanting to do something about that, as opposed to conditions where there's no discernible solution. The groups targeted, the vulnerable groups differ. Who's afflicted by the condition? In some cases, working productive adults that threaten the economic health of the society, generating attention and resources. In other cases, it's stigmatized groups that societies are not willing to try to support. And issues differ in social costs. So in some cases, the condition affects only that person, him or herself. In other cases, it may have it may transmit to other people, or it may have economic harm, cause economic harm. And in the latter type of circumstances, you can presume it's easier to generate attention. And finally, what it is we're trying to explain. So networks negotiate through their environments. They differ in ease of generating attention by virtue of the kind of issue. And what are they trying to achieve? Well, they're trying to achieve a number of things, among which is to build knowledge, research, information about what you do about it. They're trying to attract international attention and resources. They're trying to get countries to adopt policy, evidence-based policy. They're trying to get these countries to make sure everybody has access to these policies. And finally, ultimately, and this is ultimately what everybody is seeking, is they want death and illness levels to drop from that condition. So this is the framework we're working from. There's a lot of background from political science and sociology that's behind this, that I won't bore you with those details. The methods that we're using for the 6 case studies, we have 6 comparative case studies. We're using process tracing methodology methodology is a qualitative type of methodology that's particularly good at getting at causal processes and mechanisms. I won't go into the details, but it heavily involves in-depth interviews with the actors involved as well as their critics. So hundreds and hundreds of interviews with people in these networks. Analysis of documentation from NGOs, donors, research institutions, and others. Visiting implementation sites. Inputting this all into qualitative data analysis software so we can code and systematically compare. Checking our reports with individuals within these networks to ensure the accuracy. And further, the 6 teams are working together. So it's not as if the maternal and tuberculosis goes off by themselves. We meet periodically and exchange ideas that inform, and there's cross-fertilization across these. We're now starting to work also on 3 comparative reports and then a set of broader studies. For instance, questions like, how does the way in which these policy communities manage disagreement affect their ability to capture resources? So those will be some of the thematic studies. I thought that before going into each of the 3 paired comparisons, I would give you an example of one such network that we're working on to illustrate this, flesh it out a little bit. And it happens to be, in addition to supervising the whole project, I'm doing one of these studies myself so that I know what's going on and understand the difficulties. So I'm doing the one on newborn babies. And let me give you a little bit of detail about this network. As many of you may know, there are more than 3 million deaths annually to babies under 1 month of age each year. And this represents more than 40% of under 5 mortality now. It's the slowest declining component of under 5 mortality. Primarily due to complications from preterm births, birth asphyxia, and infections. Prior to 1999, there was no network on newborn survival globally. What there were isolated pediatricians in places like India, Pakistan, in the United States as well, who had some concern for newborn survival, but they barely knew each other, and they certainly weren't working in tandem. Well, this is what happened come 1999, to give you a flavor of how these things start to emerge. In 1999, this man, whom some of you may know, Bob Black, a professor at the Johns Hopkins Bloomberg School of Public Health, decided to organize a seminar at Hopkins on perinatal mortality, where for the first time he brought together a number of these isolated individuals in Baltimore. I mean, people from all over the world coming to Baltimore to talk about perinatal, especially neonatal mortality. The most important thing that happened at that 1999 meeting was that Abhay Bang, an Indian physician from the state of Maharashtra, who had been doing local-level studies on newborn survival, among other issues, was invited to attend and presented his results. Now, as of 1999, the predominant presumption was that in low-income settings, there was very little you could do to save the lives of very sick newborns. As of 1999, the predominant presumption was that in low-income settings, there was very little you could do to save the lives of very sick newborns, because to do so, it was presumed required expensive hospital-based technology, resuscitation, ICUs, and so forth. Well, Bang comes to this meeting and presents results from a randomized controlled study, which later that year he publishes in The Lancet, that shows more than a 25% reduction in neonatal mortality in an intervention area in rural Maharashtra state that was done without physicians, without even trained health workers, but very poorly educated women who were simply taught by health workers and doctors that things like you rub the baby's back if she's asphyxiated at birth. very simple things that didn't require a doctor. He presented it to a room like this, and pediatricians from around the world were stunned. They saw very simple things that didn't require a doctor. He presented it to a room like this, and pediatricians from around the world were stunned. They thought this was not possible. They had thought it was not possible in such settings to reduce neonatal mortality. But he changed all their minds. Meanwhile, at the same time, this was 1999-2000, this man, David Oot, who's head of health at Save the Children USA, was sitting with a set of his colleagues at a table wondering what new priorities Save the Children USA might undertake. Well, they heard about Bong's work. They also heard about this new Seattle-based foundation that had been founded in 1996 and was looking for new projects. And they came across the idea of a global program for newborn survival. They approached Gates, and I've confirmed this. They approached Gates, not Gates approached them, as people usually think things happen. And by the way, this was our idea, not Gates' idea. So they approached Gates and submitted a $50 million grant proposal, 6-page long. Within a month, it was funded in its entirety without modification. So back then, Gates was less bureaucratic. That launched their capacity, based on an NGO, interestingly, not a government, not a donor agency, an NGO, that began to link other folk who previously had interest in newborn survival but no institutional forum. Donor agency, an NGO, that began to link other folk who previously had interest in newborn survival but no institutional forum. So between this program at Save the Children and an informal network of mostly neonatologists and pediatricians, they managed to gain great political traction over the course of the decade for newborn survival. What were they doing? They sponsored and developed a whole series of studies that built on Bong's findings, to show indeed the tractability of the problem. They disseminated evidence on severity. Especially, they pushed the message that for Millennium Development Goal number 4 on child survival, which is to reduce by 2/3 child mortality by the year 2015 over 1990, the only way you can do that is if you get to newborn survival, the under 1 month babies, because that was the slowest declining component of under 5 mortality, and you have to push that to achieve the objective. So this resonated with policy elites. All of those folks started joining the boards and institutions of other organizations, like some of them moved to the Gates Foundation, the Partnership for Maternal, Newborn, and Child Health. They started showing up all over the place. And at the table, they would always, the Partnership for Maternal, Newborn, and Child Health, they started showing up all over the place. And at the table, they would always make sure the newborn had a place, because the newborn never had a place before. She was invisible. And I mentioned this point about MGG4. So that gives you a little bit of the taste of one of our network analyses, not the whole, not the whole picture. And I don't want to overemphasize. There's a lot of difficulties too, but it gives you a taste of how it started to evolve. Let me now turn to the 3 paired comparisons and offer you our preliminary findings, which still really need to be pulled out and assessed more carefully. So the first comparison, I remind you, the comparisons are TB and pneumonia, tobacco and alcohol, and newborn survival and maternal survival. And just to give you a sense of why those 3, broadly speaking, if you think about the whole world of global health and you were to ask all the conditions that exist, you could kind of parse it up. Some of them are diseases. like TB and pneumonia. Others are risk factors, like nutrition or risky sexual behavior, or addictive substances, like tobacco and alcohol. Still others are groups, conditions affecting particular groups, like the elderly or adolescent girls. And that's what newborns and pregnant women are. Now, there are other clusters you might think about, like systems issues. You could mobilize surrounding health financing or health workforce. Or another is interventions. You get mobilization of networks surrounding vaccination or family planning or surgery. But we've got 3 different clusters represented here, which helps us somewhat with generalizability, as opposed to if we had just taken all diseases. But here's the 2 diseases we selected. And the idea here is that TB and pneumonia are the 2 leading causes of death and illness among communicable diseases of the respiratory system. But the empirical puzzle is that although pneumonia has a higher global burden, TB has made greater progress in terms of policy attention, policy diffusion, and scale-up of interventions. Why? I won't go through all the details here, but it's an empirical puzzle. And if you consider carefully, if you go back 20 years or if you think now and you really look objectively at these 2 diseases, it's kind of a wash. If it's 25 years ago, you wouldn't have been able to predict which one would have gained global traction. So what happened? What explains this? Here's where we're gravitating, and we're still, thinking this through. And I go back to our categories of our framework: issue, characteristics, environment, and network. And let me speak to a couple salient differences. For the most part, on issue characteristics, you couldn't really distinguish. I mean, one or the other might have gained global traction, but some things to note. TB, after having been largely vanquished in high-income settings, in the 1980s starts reappearing in multi-drug resistant forms in New York and Western Europe, thereby alarming politicians in rich countries. As of the late 80s, the WHO had only 1 TB person. After this, they gained a much larger section. Now, TB hasn't diminished in low-income countries. It hasn't gone down there. But what happens is it changes in high-income countries. Well, what about pneumonia? Well, pneumonia is a persistent condition in both high and low-income countries. It's not that it goes away, but it gets readily managed for the most part. So it doesn't present some big exogenous shock like MDR-TB does in New York City. But again, TB and pneumonia persist in low-income countries. It's what's happening externally. What about the environment? Well, TB, interestingly, becomes a leading cause of death among people living with HIV/AIDS that becomes the most powerful advocacy community in global health. And this benefits tuberculosis advocacy and policy attention because of the power of folk concerned with HIV/AIDS. It benefits in mobilization and attention, and it benefits in resources. For instance, the Global Fund to fight AIDS, tuberculosis, and malaria gets established. It would have been unlikely to have been established in the absence of an AIDS pandemic, but it benefits tuberculosis. What's happening to pneumonia? Well, in the 80s, and by the way, I am not making a case for verticality. I'm just trying to observe some empirical phenomenon. But in the 80s, you do have a group of individuals who are quite committed to fighting pneumonia and acute respiratory infections, which is the term formerly used. But later in the 80s, what happens to pneumonia is the Jim Grant child survival revolution that integrates pneumonia with measles, with diarrheal diseases, the GOBI, the Integrated Child Survival Agenda emerges. And all of these diseases lose their organizational identity and their mobilization. So pneumonia gets kind of lost amidst the broader child survival agenda. For better or worse, I'm not making an normative judgment, but just showing you how you get a sense of identity for TB here and a loss of identity for pneumonia. But what about the network? Well, alongside these developments, you get entities linking hundreds of organizations, now 1,500 organizations concerned with TB in the form of Stop TB Partnership, that comes on a mechanism to address the disease called DOTS, Directly Observed Treatment Short Course, as a core intervention strategy that is at times controversial, but ultimately serves to link and convince policymakers that there's a strategy to address it, creating a network that is pushing for this disease to be addressed. In pneumonia, you get fragmentation among the actors. And while now, over the past 3, 4, 5 years, this network is newly formed, you see in the past historical tension among different intervention clusters, whether it be vaccines or community case management. So different dynamics. So why TB, more policy attention and traction than pneumonia? Does this explain it? Perhaps not completely, but one can start to see the potential causal factors as you look at network activity, issue characteristics, and environment. And just graphically, this is our pneumonia team lead put up this kind of Venn diagram of different actors in pneumonia. And the main point to note is that they have varying interests and they're not cohesive, they're not necessarily unified until recently. And the main point to note is that they have varying interests and they're not cohesive, they're not necessarily unified until recently. The second analytical puzzle, and I think this will be possibly the one of greatest interest to this audience, and I'm sure I have much more to learn from you about this than you have from me, so you can correct the errors we make here in our analysis. But the logic behind this comparison is that tobacco and alcohol are the two leading causes of death and illness among addictive substances globally, with illicit drugs being a distant third, not even close. And arguably with roughly equal burden. We've been looking at some of the latest data. And in terms of disability-adjusted life years with respect to risk factors, alcohol is higher than tobacco. And some people have been claiming that alcohol is particularly underestimated because some of these figures exclude social consequences such as wife battering that emerge from abuse of alcohol. So both serious conditions, but if you observe international and national policy attention to addressing the abuse of these substances, it's clear that tobacco has gained in low and middle income countries far more traction than alcohol. Perhaps the most salient example of this is the existence of the Framework Convention on Tobacco Control that slowly but surely is influencing national policy across the world, and the absence of any equivalent for alcohol. So how do we go about trying to understand this? Again, let me turn to a few comments in each of our categories. With respect to environment, there's a great similarity here in that both of these issues face industries that actively push the consumption of their substance. So this is quite similar across both these issues. And interestingly, we've observed alcohol learning lessons from tobacco, the alcohol industry learning lessons from the tobacco industry and how to counter attempts to control their industry. What about issue characteristics? A difference here In the 50s, 40s, 50s, and before, tobacco is publicly positioned largely as an individual problem. It's a decision that an individual makes without social costs or consequences. But 60s, 70s, largely as an individual problem. It's a decision that an individual makes without social costs or consequences. But 60s, 70s, 80s, advocates reframe this to be one that is in part socially determined. It has costs such as secondhand smoke. So it's not independent. And furthermore, some of the advocates argue that you can't just look at an individual person's choice as the sole determinant of why a person smokes or not. It's socially, economically determined as well, the behavior of the industry and so forth. It's not just an individual phenomenon. What about alcohol in low-income countries especially? We don't see this kind of reframing to social costs. We don't see a lot of activity saying this is having, in some high-income countries, yes. You can think about MAD, Mothers Against Drunk Driving. But in low-income countries, you don't get a lot of this. This is affecting society adversely. There's some exceptions, Russia, for instance, but for the most part, you don't get a similar kind of transformation. Finally, with respect to the network, in tobacco, multiple networks emerge, linking scientists, advocates, and other actors who form a pretty powerful force fighting the tobacco industry. In alcohol, while you do see smaller sub-networks in high-income countries, again, like MAD or fetal alcohol syndrome, for the most part, what you have are a group of scientists who are deeply concerned about the issue, but very few advocates, and a very fragmented network. Nothing of the kind that mirrors tobacco. So does this help explain some of this divergence between tobacco and alcohol? Perhaps, probably is not a complete explanation, but we're pushing to try to understand this difference. Again, the idea is that there may be some characteristics of the issue itself that make it easier or harder for one or other to promote. But it's not just that. It has to do with the behavior of the people who are fighting the condition. Harder for one or other to promote. But it's not just that. It has to do with the behavior of the people who are fighting the condition. The third paired comparison is newborn and maternal survival. And I'll call it a presumed puzzle, and I'll explain why I say that. These are two groups highly vulnerable at birth. And if you look at mortality and morbidity, similar seriousness, many more deaths to newborn babies than to pregnant women, but huge numbers of injuries, long-term complications from complications at birth to women. So two very serious issues. Newborn mortality, as I just mentioned, only gets its start in 2000. Maternal gets launched in Nairobi initiative in 1987, 13 years earlier. But apparently, there's been more rapid progress for newborn, at least as of 2007, when we were thinking about this study. Because by 2012, newborn has become a priority for global organizations and governments, whereas maternal, as of 2007, really had seen disappointing policy traction. So why is it that, despite similar issues, the one that got started 13 years earlier had less success? At least that was our initial question. But then positive developments messed up our research design. Which I'm happy at these positive developments, so we'll just adjust. What happened post-2007 is that you get this incredible traction for maternal survival on the global stage. You get a UN global strategy for women and children's health launched by the UN Secretary General. You get $40 billion in commitments, and you could possibly make the case that actually now the maternal folk are leaving the newborns behind. But it's still, there are some interesting comparisons and questions to ask about this, such as why, after 2 decades of struggle, does maternal take off? And what are some of the common causal factors that shape both of these initiatives, and how did they learn from one another? So there is still interest in seeing the two together, although if not explaining that variance. So there is still interest in seeing the two together, although if not explaining that variance. Some points of comparison. In terms of the global environment, interesting to note that in Millennium Development Goal number 5, it is a maternal survival, maternal mortality Millennium Development Goal. So pressure on nation states to keep that. Newborn, although not explicit, it's really part of MDG 4, the child survival Millennium Development Goal. They both have MDGs. Similar issue characteristics. There's growing but still uncertain evidence on the tractability. And the way in which these two policy communities manage this it becomes a very important point for analysis. But an aspect of network that's particularly salient in trying to understand their trajectories is the fact that the maternal survival actors for 2 decades are hampered extensively by disputes over what is to be done, intervention disputes. Do you focus on skilled attendance at birth, on emergency obstetric care, family planning? For 2 decades, they struggled to come to a consensus. In 2007 and thereafter, they come together. But what's interesting is the newborn folk closely pay attention to these intervention disputes and keep their own disagreements in-house. So they manage disagreements effectively so as not to affect the public perception of the tractability of the problem. So 2 slides to conclude some of the key preliminary points. We've been trying, again, to understand factors that may be affecting the formation and effectiveness of networks and their ability to shape policy and public health outcomes. And we've identified some presumed causal mechanisms at work. With respect to environment, the influence of other health priorities, for instance, how AIDS helps TB gain traction, how child integration hampers pneumonia advocacy, how opposition affects policy attention, the tobacco industry as a barrier, but also as a source of energy, galvanizing mobilization to address tobacco, so it works both ways. Global agreements, how the Millennium Development Goals, as the United Nations member states agree to these, shape pressure on nation states to address these. With respect to issue characteristics, severity, how high mortality is a spur for all these networks, how tractability becomes a key concern, and a clear strategy surrounding DOTS for TB helps shape advocacy and attention for that issue, but the uncertainty on newborn and maternal hamper attention. How the group that is targeted matters. So, for instance, TB is surprising Americans. That's good for TB in terms of attention and resources. Whereas maternal and newborn deaths, and I didn't mention this before, but they're only a problem for poor countries, well, largely. Of course, we still have some problems, but 99% of maternal mortality is in low-income countries. It's not a threat to rich countries. The social costs that are identified in tobacco and less salient for alcohol. And finally, network structure. For instance, the formal network for TB and the Stop TB Partnership spurs global action. The fact that alcohol consists predominantly of scientists, they haven't linked up with other groups, inhibits action. And strategy, how maternal network manages disagreements poorly and the newborns learn from this in order to not repeat the same mistakes. So finally, what are the emergent themes from this work? Well, first and foremost, we have to think carefully about the influence of network strategic management and how these networks differ in their strategic management capacities. Some are managing disagreements very well. They're developing organizational structures that work for their issue. They're making social cost arguments, economic arguments, that frame their issue beyond some of the other framings to appeal to elites. They're developing interventions well, and they're essentially negotiating through their environments. They're cognizant of their environments. They're aware of these and taking advantage. Other networks are doing some or all of these functions quite poorly. The second point is, and if you recall, I mentioned the bidirectionality of the arrows on the initial chart. They're not one way. All three of these, or all four of these components are shaping one another. So, for instance, the issues affect the networks. If there's a lot of people dying from a condition, individuals and organizations are attracted to address it. But vice versa, the networks shape the issues. These actors themselves are actively seeking out and portraying data in order to convince others that their condition deserves attention and resources. But also similar with respect to environment and actors. The existence of opposition to tobacco control galvanizes the tobacco control activists. Likewise, the tobacco control activists cause the tobacco industry to revise its strategy. So environments and networks are mutually causally influential. I could do the same for all four of the categories. I won't, but you get the idea. Final point is to discuss the role of institutional and individual agency. I mean, ultimately, these networks are trying to change mortality and morbidity. And here, this is the trickiest thing to assess causality. As you go down the causal chain from network all the way to mortality, it becomes very difficult to sort out what's causing what. I'll just point out one thing, is that we do notice declining TB, neonatal, maternal, and pneumonia mortality across time, but to date, it's only, we can really only detect a large impact of the TB network on public health impact. We can detect impact on policy outcomes for the other networks, but on the actual public health impact, only for TB. So it just raises the question, how much difference are these networks making? Maybe a lot in some areas, but not others, or maybe ultimately not much. We don't know at this point. So I'll just conclude there, and I look forward to your questions and comments on this project.